perspective. Amoeba.
Okay, thank you, Mike. I'm very pleased to be here to have an opportunity to meet people and listen to what people are saying, and also particularly listen to John, because it's always useful to get one's information brushed up. We're always very conscious in the faculty that a large proportion of our members work in the private sector, and many are single-handed, so it's always good to have an opportunity to engage and listen and talk, so very pleased to be here. I should say, by way of caveat, I am not Ms. Revalidation in the faculty. My colleague Rachel Cooper, who's head of professional standards, is not surprising, it's another revalidation meeting, and Rob Thornton, who's the director of professional development, and he's currently our interim responsible officer. He wasn't able to be here either because he had clinic commitments. So I'm sorry about that, but I said I would be pleased to come along and meet you and just to tell you where we are with regard to revalidation in the faculty. So although I'm probably a poor substitute, I can tell you something of what we've been doing, and any questions that I can't answer, I'll very happily take back and get the answers for you by people who do know. I think the first important thing to say is when I say the faculty, talk about the faculty, what we're proposing for revalidation, I mostly mean about the responsible officer system. This is very much the focus of our work at the moment. And I realise there are here other responsible officers, and I think there's probably some mutual empathy in us all trying to work out what our duties are. For us in the faculty, they're a little bit different in the sense that our responsibilities for doctors extend across many organisations and to many doctors who are not in organisations. So our network is a little bit more complicated. To recap on what we were just saying about pathways to find your responsible officer, unlike most medical royal colleges and faculties, the Faculty of Occupational Medicine, together with two other faculties, it's pharmaceutical medicine and public health, we do have and must have a responsible officer. We're all specifically named in the regulations, and by the regulations, capital R, it's the Medical Professional Responsible Officer Regulation of 2010. And I was talking to my colleague Rachel, and I said, what are the key things that people should have on their, well, probably on their desk rather than their shelf, unfortunately. And I think one is, and I do swear to you, this sits on my desk, the regulations, and they're not, a lot of this is some of the guidance attached, they're not that long, and worth knowing where they are and referring to them when you need them. Some 3 or 4 years ago, when the regulations were being developed by government, we realised that it wasn't going to be an ideal situation for occupational physicians, and especially occupational physicians working independently, to be assessed by doctors who don't at all work in the field of occupational health and don't understand the context very well, and who have no relation to the specialty. So we had discussions with the Department of Health about the need for an RO for the specialty, and this point was accepted, and we now are a designated body, and we have an RO. So whilst we have been relaying general information and to our best of our ability about revalidation to the members, really our focus is on how to access your RO and how we're going to develop the RO system for occupational medicine. Some of the key areas of work we've been involved in, we've developed, sorry, excuse me. We've developed supporting information for appraisals and revalidation, guidance for occupational medicine, and I think this is the second chunky document I would refer you to. It's on our website. It's published by the Academy of Medical Royal Colleges and us jointly, and it's called Supporting Information for Appraisals and Revalidation, Guidance for Occupational Medicine. And we worked with the Academy, and all the specialties did, to work out the general guidance, and then we've added notes to it about how it specifically applies to occupational medicine. So I think that's another useful document. It covers all the information which you'll need to gather for revalidation. So the scope of practice, because as John has said, revalidation is going to be based on revalidating you in the areas in which you are practicing. Record of appraisal, personal development plans, probity, health, CPD, review of practice, outcomes, colleague and patient feedback, complaints and compliments. Covers all that and talks about how they apply to occupational medicine. Another building block working towards the revalidation, the responsible officer system, was our revalidation pilot, which we did last year in 2011. And we did this in conjunction with the other two faculties which are designated bodies. and I'll come back to that in a moment. And a third element which we're working on is the development of an integrated, electronic system, this won't be a shoebox affair, based on all the requirements that we have to meet from the GMC. But just going back to the pilot for a minute, just so you know, we have been trying to test this out and also improve the system, having tried it out. We were looking for about 50 doctors to volunteer. We got 48, and we also had some nested pilots with the Ministry of Defence, Health Management Limited and HSE. They were organisations that volunteered to be part of this. A few withdrew or failed to complete in time, but 44 of the appraisers said there were no concerns. There were 33 positive responsible officer recommendations, dummy recommendations obviously, and there were 12 applications for deferral. And I think the important thing to say about deferral is, which you mentioned, this wasn't because there was anything amiss with the doctor's practice, but it was lack of information, insufficient information. So I think that's one message that you always have to say. Do find out what information you need to get up there, load onto the system, because a full uploading of the information is important. We also did a quality assurance system, and the other two faculties, all the 3 ROs, did a blind test of each other's recommendations. And they did this for 26, and 23 were agreed and 3 disagreed. So it was very much a learning process about creating consistency and doing the job properly. A couple of the areas of feedback we got. One was some people found the electronic system clunky, and take that on board entirely and have been improving it. And also multi-source feedback. And it's a bit the point you raised, if you're a single-handed practice in particular, how do you do that? Not an easy answer. We're working with the Faculty of Pharmaceutical Medicine, because we're sort of sharing out jobs between us, which is a very nice and cooperative. They're looking at identifying, there are companies that provide MSF tools, and also we're looking at how this might best apply to us, so more information to follow on that. So we're now concentrating on fine-tuning the system, hopefully we've got to that stage, and also on interpreting the regulations for occupational medicine, and particularly as they should relate to the circumstances of our specialty, and given that there are many in the private sector and many single-handed practices. And a lot of the things that people have said today, they have been taxing us too. We've been having meetings with our employment liaison advisor from the GMC, and with the head of implementation at the Revalidation support team, and with NHS London, because again, this reflects what you were saying, because we're where we are, our RO is responsible to the RO in NHS London, and so we are responsible, the faculty is responsible to NHS London to report how well we are prepared for providing a responsible officer. These authority bodies, I have to say that everybody's been very helpful, and they understand that we're different, and they are trying to help us work out some interpretations. And I think we've got some way to go on that. In particular, for instance, how we take forward investigations and remediation. It's not so obvious. I'm obviously for a medical director in a hospital, it's quite clear how you do that with your doctors. It's not so obvious to us who are dealing it very much at arm's length. But we're just taking further advice on that. Some of you may have been at our annual scientific meeting where Sir Peter Rubin, the chair of the GMC, was. And the word that he said quite a lot, which we wrote down, was pragmatic. And we have taken that on board. And we're really trying hard to find a system which is going to be workable for everyone. That having been said, we are aware that we have a heavy legal responsibility. There's a statutory requirement. It is about the protection of patients and the public, and I think there's clearly a consensus here and across the country that this is a very good thing to be doing. And we're conscious that we, as an organisation, and our responsible officer personally, will have quite a big legal responsibility. So it's a balance between making sure we carry out our statutory functions and trying to make the system workable and appropriate. But I think it's not a light undertaking, and it's not a tick box affair. I think, yes, it was said that. I think probably you should say, going on to the little pathways document which I handed out, in terms of who can access the faculty responsible officer, this applies to any doctor who has a prescribed connection to us, and hopefully you can work that out from the diagram. I have to say it's not always clear, and you may need to take further advice.
Can I just ask what you mean by member? You say,
Yeah.
would that include associates and diplomas?
Yes.
Or, yes.
Yes. You can trace that and see where your prescribed connection lies, and therefore which is your designated body and who is your responsible officer. And just to reiterate, there isn't a choice about this. For doctors in the NHS and large organisations, obviously it is quite a lot simpler because your senior doctor will be usually your responsible officer. But for doctors working in occupational medicine, and especially those in small companies or single-handed practices, that's not so obvious. And those are the doctors who I think our responsible officer system will be most appropriate to. So all our members will be able to access the faculty responsible officer, and that, yes, across all the ranges. So, and we envisage that it will apply to fellows and members and associates and affiliating diplomates, that is, people who have one of our diplomas. The board has also created a new category, and this is for doctors who do not have a formal faculty qualification but are spending most of their time working in occupational medicine. They will be able to join and access the RO. And this next point about working with other companies also reflects a question that was raised earlier. As well as providing an RO for our members, we're also offering this to other designated bodies, appropriate designated bodies. So companies which are designated bodies within occupational medicine will be able to sign up with us and have a formal agreement. So I say in developing this system, we are very acutely aware of our own statutory duties, but we're also conscious that it can be quite a difficult time for doctors who haven't entered into this system. So we are planning a support system of specialty advisors, and we've got some funding from the Academy of Medical Royal Colleges, and we're setting up a bank of about 10 senior doctors who will be well versed in the system, who will be able to advise you on things like what sort of evidence should you use in what sort of circumstances. And we envisage this will be particularly useful where doctors are not doing mainstream clinical work and where it's not obvious what sort of evidence you should use. So where are we now? We've been sending, I hope we haven't been bombarding too much with listening to what you were saying, but we've been sending various letters and notifications out to our members and put lots of information on our website. Just trying to keep them up to speed with what's happening, and also with especially at what's happening at the moment in terms of identifying your designated body, and I'll come on to that in a minute. We've advertised the responsible officer role. As I say, Rob Thornton is our interim responsible officer because he's done all the development for us. We're now making a substantive post out of this. This will be a paid part-time post, and applications are due in by 13th of August. Last Friday was the date by which we had to send to the GMC a list of doctors for whom we are the designated body, and I say a list. I'll come on to that. This has entailed matching the GMC information, so people have written to the GMC and they've said, I think I'm with the faculty, and they've written to us and said, I think I'm with you. We've got our list together and been double checking and checking they are really members of ours, etc., etc. And we've settled down the current number, and it's going to be very much a moving feast, is 240 doctors for whom we are responsible. So it's going to be moving, because obviously doctors will move jobs for one thing, so they might move into a designated body which will take precedence. So it's important to say that the list that we sent to the GMC is a list and not the list. And so if you haven't yet identified your designated body, not all is lost, but now is the time to do it, I think. It's also really important to be clear, and this is one of those areas it's quite tricky in occupational medicine, whether your employer is a designated body. Because if your employer is a designated body, they must be your RO. And so if you are in doubt, or your employer is in doubt, do take further advice to make sure you make the right connection. And please do correct me on anything I say. No. Yes, I said we would be offering our RO, it's quite hard to say that, our RO, to other designated bodies, which is true, because once we've got the system up and running, we think there's something we'll be able to do quite easily and be a useful service, especially for smaller companies. In this case, it's important to stress that our relationship will be different. Whereas an individual doctor who is a member of ours who doesn't have a prescribed connection elsewhere, we are their RO, and that's a simple relationship. Where you are employed by an organisation which is a designated body, we have to have a formal arrangement with that designated body to say you are really a designated body, but we will be the RO for your people. So there's a sort of connection with the individuals involved, but also a connection with the organisation. So that we're just in the process of working out the detail of what those sort of arrangements will be. And yes, if you're not sure, look at the little map and go to the GMC website that has loads and loads of information. As you've said, they have a helpline. Another useful means of support is the revalidation support team also now has regional people. We're currently in the process of finalising the agreements that we shall have to set up with our doctors whom we're responsible and the organisations who want us to be their RO. We know that the fee for revalidation for the responsible officer service is going to be £240 plus VAT. And in terms of next steps, I think the important messages are check your prescribed connection if you haven't already done so. Tell the GMC who you think it is, and if you think it's us, please tell us. Get signed up for appraisal, and there was mention before about the SOM appraisals. SOM is the Society of Occupational Medicine. They've had an appraisal system running for some years, and it seemed very neat when all this came up that we could work in partnership with them and use their appraisal system to feed through to the responsible officer system. That's what we did in the pilot, and it worked very well. It's a quality assured system. If you're in occupational medicine, we're recommending that is the most straightforward place to go for your appraisal. We shall shortly be writing out to doctors to find out how ready they are for revalidation, those doctors on our list, and this will include asking them whether they've got arrangements in place for appraisal. My understanding is that we're going to be asked to make recommendations for revalidation. I thought we had to make some before March 13. Is that correct?
Well, the plan in England is that the responsible officers will be in the first wave, which will be between January and March.
Just the responsible officers?
Well, and a few some other kind of what you might call medical leaders within the system. The main body of doctors will then be scheduled from thereafter.
Right. Okay. So we start proper really then in January next year, and we understand that we shall have a target of trying to get about 20% of doctors through in our first year proper, and yes, segmenting them into quarters. And as you said, the GMC will be informing doctors when their revalidation date will be. So I think in conclusion, the key documents, and when I say my desk isn't always the tidiest place in the world, but it does have a lot of documents on, but the ones that I put my hand on and need most often are the pathway, the actual regulations, because going back to the real regulations, a bit like saying go back to the guidance, sometimes the guidance is very NHS oriented, so I think if you get it from the horse's mouth, go to the regulations, and the Academy of Medical Royal College's document about supporting information. Double check that you're in the right designated body and that your employer is or is not a designated body. I think those are the key messages that you need to take on board at the moment if you haven't already. And just to say, we're trying really hard to balance our statutory responsibilities with trying to make it workable for members. And we shall carry on trying to do that. But it's really useful to have dialogue because it's been very interesting picking up what you said today, and I certainly will take all those thoughts and comments and perspectives back. If you have any queries or comments or concerns or ideas, please do tell us. We have an email which is professionaldevelopment@fom.ac.uk, and we will do our best to help. Our RO will bring an RO to their doctors.